Good evening, friends. And sorry for the 5-minute delay. There was a crisis with some patient. So today we are talking on interpretation of routine urine analysis. One of the, or rather I would say the commonest investigation that we do in our practice. One of the commonest lab investigations ordered by both family physicians and after hospitalization. If properly interpreted, if you look at every variable of the report, it can give you tremendous information about physical, chemical, and microscopic characteristic. And since urine is a product of kidney, it gives you information about the kidney and many times about the body system also. And then it can guide you. It may not give you the specific diagnosis every time, but it will guide you to the proper diagnosis or maybe differential diagnosis. Biggest practical problem that we have in practice is contaminated urine sample. You have a patient who has pus cells 150, 200. Patient is afebrile. Patient has zero symptoms. Yes, it could rarely be sterile pyuria. But in almost 90% patients, when they are explained that how to collect a sterile sample of urine, the pus cells disappear and become 0 to 5 only. What are the samples taken for urine analysis? Routine. कमलेश भाई एक लेक्चर ले रहा हूँ 7 बजे फोन करूं? Routine sample, which we always say, but routine should be sterile. It could be first sample, fasting. If you are doing macroalbuminuria, you need first sample of the morning and it should be freshly voided. If it is a routine test, not macroalbuminuria, then it should be freshly voided and given to the lab as soon as possible. We don't want first sample of 6 o'clock given at 10 o'clock or 11 o'clock for a investigation of routine urine analysis. Should be midstream. Or if the patient is in the hospital, you can give a catheterized sample. How do you collect sterile urine? I think most of us are so busy in our practice that we do not spend time in explaining the patient how to collect the sterile urine. And it is more difficult in case of women, especially by a female doctor, by a male doctor. Culture antibiotic sensitivity, if you're asking, it should be freshly voided. 24-hour sample in some cases are done either for proteins when you are suspecting nephrotic syndrome or for 24-hour calcium. Random sample is any time of the day with no precaution regarding contamination. You don't even bother. Patient collects. Which container they collect also you don't know. It could be a pickle bottle, masala bottle, sweet bottle, we don't know. The sample may contain white cells, bacteria, and squamous epithelium as contaminants. And then you have to decide. And many of us, without thinking, pick up a pen and write an antibiotic. In females, the specimen may contain vaginal contaminants like trichomonas, yeast, and during menstruation, RBCs. Early morning sample, the first sample, fasting sample, before ingestion of any fluid. So people who say that I wake up 3 times in the night, so I'll say around 5 or 6 a.m. sample you give. You don't have to give 2 o'clock sample. This sample is usually hypertonic and it is normal hypertonic. It reflects the ability of kidney to concentrate urine during the night, avoiding patient to void recurrently. Even a normal healthy adult without prostate passes urine. 1 second, my emergency continue. So first sample, if it is done without any intake of water, it turns out to be hypertonic, don't worry. Midstream sample, you have to tell the patient, roughly divide the urine stream into 3 parts. First and third to be discarded, middle one to be collected. Midstream describes the middle part of the urine flow, not to collect the first or last part of the urine flow. It's collected after cleansing the external urethral meatus. If a male patient, where it is easy, retract the prepuce if not circumcised, clean the external urethral meatus even by tap water, then that becomes a sterile sample. The first part of the bladder urine is discarded, and then most of the contaminants are flushed out. Then middle 1/3 is taken. Catheterization only in special circumstances, we don't bother about that. Coming to sterile sample, how do you explain the patient? Male patient, retract the prepuce, clean the external outer urethral meatus, and collect midstream sample in a bottle. For females, there are 2 ways. Wash hands. If the female is not obese, if she can sit on a commode like this and then collect in a container, holding the container in front of her introitus, again midstream sample, that's the sterile sample. Obese patients cannot collect like this. So what we tell them is, you stand in the toilet, wash your private parts, put your 1 foot on the commode, and then holding your labia separately, let the urine fall in the container, midstream sample. That's a sterile sample. Once explained, all urine samples in them should be sterile samples. And we have had great success in this. Patients who keep running from doctor to doctor with 10 reports of pus cells, 50, 100, 125, come out to be 3 pus cells. What the volume of urine? An healthy adult passes about 1500 ml of urine on an average intake of 2500 of fluid. Our total fluid intake, including water and other things, has to be 2800. So if you take approximate 25, you'll pass 1500 ml of urine. Oliguria, defined as a daily urine volume of less than 500 ml daily. All patients who are severely dehydrated, you have to ask them to measure the volume of urine that they pass. Keep passing in a Bisleri bottle, which can be discarded later. Or a patient of CKD with infection, start monitoring the urine volume. Anuria is defined as a urine output of less than 50 ml per day and suggestive of either some obstruction if the onset is abrupt. Doctor, I was passing normally till 4 p.m. After 6 p.m., I just can't. And if the patient is elderly, prostate related, or some other obstruction. Otherwise, anuria is a acute kidney failure. Diagnosis of oliguria, anuria without intake output chart or without measurement is suspicious. Color of the urine. Normal fresh urine, pale to dark yellow or amber, based on how much hydration the patient has had previously. Dark, high-colored urine is concentrated urine. If a patient comes to you and says, I pass dark urine, you ask, every urine is dark or only first? No, only first. That is concentrated urine. If it contains many RBCs, it may be cloudy or maybe red. Tea-colored urine also may have blood in the urine, but should be checked. Red or brown color urine could be from food dye, eating plenty of fresh beetroot, or food colors used in roasting or making tandoori. The tandoori orange color earlier used to be in a very expensive color. Now they are available in 10 and 20 rupee containers. And I myself have suffered. You eat tandoori from a so-called renowned place. Next 12 hours, your urine is orange color. So that means that dye is going out. Drug rifampicin or furazolidone that is now banned. Furazolidine would give dark brown color to the urine. Rifampicin we know gives reddish color. If there is hemoglobin or myoglobin present, it could be dark, bright yellow, but bright yellow urine could also be due to taking multiple B complex vitamins. So that's why the vitamins are going to the fish in the sea. Blue or green, either food colors, ask the patient, because a lot of tandoori items are made with green color. Nowadays, there are mocktails available with blue color. So ask the patient, have you consumed anything with blue and green color? Or it could be Pseudomonas aeruginosa bacterial infection that may cause urine to turn blue or green. So if the patient is symptomatic for urinary infection and has green or blue color urine, please get a culture ABS done. Appearance. Normal urine is clear. When the urine does not have the characteristic clarity, it's referred as cloudy, turbid, or foamy urine. Foamy urine may be also a lot of bubbles coming up, could be high amount of protein. Cloudy or foamy urine may occur occasionally due to mild dehydration and corrects itself. If a patient complains of foamy urine, get little more history. Male patient passing urine after a long gap, that means the bladder is full. In a commode, if the urine is falling with pressure, naturally foam will be generated. Persistently cloudy urine. Protein or crystalline substances in the urine, causing it to persistently appear cloudy or foamy. Again, you need a good analysis, preferably in a lab, not with strips. Infection anywhere in the urinary tract, including the bladder or urethra, will give you persistent cloudy urine. Vaginitis. If the patient has leukorrhea, may not have UTI, that vaginal discharge will contaminate urine and give you a cloudy appearance. Smoky urine indicates more RBCs in the urine. Specific gravity, a very important variable of the urine report. It measures the concentration of suspended particles in the urine and the density of urine compared with the density of water. Measuring specific gravity is an easy and convenient way to evaluate a patient's hydration status. Normal, overhydrated, or dehydrated. And that also tells about the functional ability of kidney to maintain the specific gravity. Normal results in adults generally range from 1.010 to 1.020. It's called as 1010 to 1020. Abnormal results are below 1010 and above 1020. Low specific gravity. Excessive fluid intake, patient is overhydrated. Hyponatremia. The text in red indicates that these are the things that we can think of in our practice. The commonest cause of hyponatremia, especially in a patient not on any antibiotics or antihypertensive or diuretics, is overhydration. There are people who drink 6 to 7 liters of water a day. Diabetes insipidus and other causes of polydipsia, which we don't see generally much. Glomerulonephritis, in addition to low specific gravity, will have a cloudy appearance because of proteins. Pyelonephritis also will be very cloudy and low specific gravity. Aldosteronism, again not our field. High specific gravity. Excessive water loss, patient is in dehydration, especially in older or pediatric patients. Diabetes mellitus, uncontrolled, you will have high specific gravity. Congestive heart failure. Glycosuria, again uncontrolled diabetes. Hypernatremia and syndrome of inappropriate secretion of antidiuretic hormone, again not our field. Reaction of the urine or pH. Depending on the person's acid-base status of the blood, the pH of urine may range from 4.5 to 8. Now, as I said in the beginning, that looking at a urine report, you can get the idea of the acid-base status of the patient's blood also. So, if the body is secreting acidic or alkaline urine, it's one of the most important mechanisms by which the body maintains pH of the blood. Kidneys maintain normal acid-base balance primarily through delicate electrolyte balance. That means sodium is reabsorbed and tubular secretion of hydrogen and ammonium ion occurs, and thus pH remains normal. Urine becomes increasingly acidic as the amount of sodium and excess acid retained by body increases. Metabolic acidosis will have pH below 5. So you have a patient, diabetes uncontrolled, asthma, severe asthma with high fever, and urine pH is below 5. You can be almost certain patient is in metabolic acidosis. You can get serum soda bicarbonate. Alkaline urine usually containing bicarbonate carbonic acid buffer, normally excreted when there is an excess of base or alkali in the body. Urine is an ideal medium for bacterial growth. That's why we say that culture sample should not be made to stand for long, either in the lab or at home, should be given immediately for analysis. Factors that make it unfavorable for bacterial growth include a pH of less than 5. So acidic urine, the bacteria does not grow. presence of organic acids and high level of urea. A highly acidic urine, that means pH of below 5, occurs in metabolic acidosis, diabetic ketoacidosis, uncontrolled diabetes with or without any infection, may not be UTI. But understand, UTI is the commonest infection in a diabetic, whether controlled or uncontrolled. Diarrhea, dehydration, starvation. When people are starved, the urine becomes acidic. Respiratory diseases in which carbon dioxide retention occurs and acidosis develops, that means asthma, COPD, pneumonia, obstructive sleep apnea. What the significance? As I already told you, a patient of severe asthma, a patient of acute exacerbation of COPD, if has fever and looking sick, the pH in urine acidic below 5, 4, 3 suggests that severe metabolic acidosis and patient may require hospitalization. Highly alkaline urine, that means pH above 8, obstruction of the flow of urine, either a mass in the bladder or a bladderenic obstruction or a prostate. Renal tubular acidosis, chronic renal failure. CKD patients will have alkaline urine. Respiratory disease that involve hyperventilation. People who are hyperventilating, not maybe acute attacks. And aspirin intoxication, which we don't see very often nowadays. During sleep, because our ventilation decreases, our body's breathing, although going on, is at a very slow pace. That causes some amount of respiratory acidosis. As a result, the first urine in the morning is usually highly acidic. Again, should not worry. Bacteria which cause a UTI will give alkaline urine. That is why making it acidic helps the bacteria not to grow, and your antibiotics will kill the bacteria. A diet rich in citrus fruit, most vegetables and legumes, peas, will keep the urine alkaline. Blood pH does not change with this. Although it might seem that citrus fruit should have acidifying effect. No, we all think, oh, citric acid, it should have effect for acidifying. No. Citrus fruits make the urine alkaline, except lemons, plain old limbu. This citric acid, they contain actually has an alkalizing effect in the system. So lemon will be acidic, all other citrus fruits are alkaline. A diet high in meat products, red meat, chicken, beef, pork, or fish will keep the urine acidic. Urine pH is a very important screening test for the diagnosis of renal disease, respiratory disease, and certain metabolic disorders, but only with clinical correlation. It can guide you, but it cannot give you pinpoint diagnosis. So as I already mentioned twice, that patient of COPD, patient of uncontrolled diabetes, with this, suspect this. So always, now, all of you, please think when you look at a urine report, do you look at the pH or no? Why are we are talking so much on pH? I've spent 8 slides on pH. It has a clinical significance. The formation of renal stones is related to urine pH. Patients being treated for renal calculi are frequently given diets or medications to change the pH of the urine so that kidneys don't form stones. Calcium phosphate, calcium carbonate, and magnesium phosphate stones develop in alkaline urine. When this occurs, the urine is kept acidic to avoid. What is the best way to keep the urine acidic? Is to give vitamin C tablet 500 milligram BD. Or there is a tablet called Cital H, which is an Ayurvedic tablet. They claim that they can make urine acidic. Uric acid, cysteine, and calcium oxalate stones precipitate in acidic urine. So in these cases, you need to keep the urine alkaline. The brand names are Alkalizer, Alkalith, Cital UTI, and Citrosoda. They help the urine keep alkaline. Then, antibiotics also have efficacy at different levels in different urine pH. Fluoroquinolones, norfloxacin, ciprofloxacin, levofloxacin, moxifloxacin, cotrimoxazole. I don't know how many of you use cotrimoxazole still. Those who are using will be happy because it has a very good effect since the large population has stopped using. Aminoglycosides, gentamicin, amikacin, and macrolides all function optimally at alkaline pH. The tetracycline, nitrofurantoin, and many of the beta-lactams exhibit high activity under more acidic urine. So depending on which antibiotic you are giving, you need to give the urine acidifier or urine alkalizer. Sulfamethoxazole, oxacillin, amoxicillin, clavulanic acid, vancomycin, imipenem, clindamycin, not affected by pH. So if we're giving an augmentin to someone for UTI because the culture report shows so, acidic alkaline makes no difference. Proteins. Protein, we know, is very important for body building. So ideally, protein should not be found in urine. Normal total protein excretion in a day does not usually exceed 150 milligram in a 24-hour sample or in a full day, or 10 milligram per 100 ml in any single specimen. More than 150 milligram a day is defined as proteinuria. When the presence of urine is more than 2 plus, it may be an indication of some disease of the glomeruli. Commonest being if it's a child, glomerulonephritis, if there is fever, and may develop into a protein-losing nephropathy like nephroptic syndrome. So you have a child who has a fever, you have given antibiotic for the throat, it's not going, and the child starts getting smoky urine and protein there, proteinuria, smoky urine, maybe occult blood present, acute glomerulonephritis. Market proteinuria, 3 plus or 4 plus, protein more than 3.5 gram in a 24-hour sample is significant for nephrotic syndrome, or rather it's diagnostic. You give a 24-hour sample of urine, it has to be collected in a special container which has some chemical in it, 6 a.m. today to 6 a.m. tomorrow. If that protein is 3.5 gram or more, that is diagnostic of nephrotic syndrome. The cause of nephrotic syndrome could be anything. Hypertensive nephrosclerosis, hypertension related kidney damage, SLE, systemic lupus erythematosus, congestive heart failure, renal vein thrombosis. But for us, commonest is nephrotic syndrome. Microalbuminuria, very important test. I don't know how many of you are doing it. Is to detect micro quantities of albumin in the urine. Quantitative estimation, not qualitative, not +1, +2, +3, +4. 30 to 300 milligram in a 24-hour period is microalbuminuria. Above 300 is macroalbuminuria. The American Diabetic Association recommends that people with diabetes receive a macroalbuminuria urine test every year after 5 years of having the disease in people with type 1 diabetes and at the time of diagnosis in type 2 diabetes. So all our hypertensive and diabetic patients should be subjected once a year. Macroalbuminuria positive 70, 80, 90, 100, 120 is reversible by giving ACE inhibitors or angiotensin receptor blockers. And this macroalbuminuria is an indication that this patient is likely to go into chronic renal failure in 8 to 10 years' time. And you can reverse it. This is one of the reversible conditions. Glucose, again like protein, glucose should never be present in the urine. The renal threshold is 160 to 180 milligram percent. So only after blood sugar goes up above 180, it should appear in urine. When blood glucose exceeds this level, proximal tubules become overwhelmed and begin to excrete glucose. Nowadays you must have seen that we don't go by glucose in urine to manage our diabetes. Because if the patient passes urine at 4 o'clock, that is previous 2 hours glucose in the urine that is being picked up. It is not a 2-hour post-lunch sample. Titration of treatment, we use blood glucose reports and not urine glucose levels. Ketones. Very important finding in even non-diabetics. Ketone should normally not be found in the urine. It results from either diabetic ketoacidosis if the patient is a diabetic or some other form of calorie deprivation, starvation. So if you have a patient of fever, 3 days, 102, 103 fever, and I do a routine urine and it shows 2 plus ketone, that tells me patient has not had sufficient nutrition in last 24 hours at least. Ketones in a pregnant patient with hyperemesis gravidarum could be a reason for medical termination of pregnancy. It is very harmful to fetus and mother. In a diabetic, ketones present large quantity with patient having some infection or high fever, suspect diabetic ketoacidosis, and please admit immediately. Bilirubin, urobilinogen. Its presence may suggest hepatocellular disease or presence of hepatobiliary obstruction, early signs of jaundice, biliary status. Urobilinogen, small amounts may be normal in urine. Increase may be indicative of liver disease, viral hepatitis, congestive heart failure, or hemolytic anemia because of RBC breakdown. But again, you will not diagnose jaundice or hepatitis on bilirubin in urine. You will get a liver function test done. WBCs. This is the crux where we see mostly the reports. White blood cells up to 5 are considered normal because of contamination. May indicate about 10 may indicate inflammation or infection. Up to 5 are taken as normal. Now, people who evaluate by strips, I just want to highlight the practical difficulty. Look at this strip. It has 3 and 3, 6 and 3, 9 and 2, 11 discs of different colors. The person who's looking at it has to see the color of 11 level variables in a matter of 20 to 30 seconds. Otherwise, the colors change. So for us, although it may say it can give us everything, but I would still depend on a lab report rather than a strip report. RBCs versus WBC. Let's see what is the difference. White blood cells, so-called pus cells, more than 5 to 10 white blood cells per high power field may be an indication of contamination if there are zero symptoms, inflammation or infection. Red blood cells, normally 0 to 2 per high power field. More than 2 per high power field may indicate menstruation, infection, trauma, even sexual intercourse next morning can give you some RBCs. Masturbation previous night. Please develop skills to ask this question to the patients. Nephropathy or glomerular damage. RBCs large in amount either could be due to a stone or bleeding due to other causes. RBCs 4 plus, 5 plus, or the report says field is full of RBCs. First doubt is renal cell carcinoma or there is frank blood in urine. Now see, we have large number of RBCs, less number of pus cells. This is hematuria. I will not treat this 10 to 20 pus cells. Malignancy must be ruled out with ultrasound after preparation because we don't want ultrasound going waste saying that gaseous pseudocene, SOS, contrast in a CT scan. This is one cancer which is easily curable because it never goes silent. Symptoms are frank hematuria, and if diagnosed, one kidney can be removed and the patient virtually recovers. UTI will have, suppose I'm giving a hypothetical picture, pus cells 80 to 10, 80 to 100 per high power field, RBCs 20 to 30, this is UTI. Severe infection will give some RBCs also. And if it is stone or bleeding due to other causes, you will get RBCs 80 to 100 and pus cells 20 to 30. This is not UTI, this is bleeding due to some other cause. Occult and frank blood seen, the patient is not menstruating, male patient, consider bleeding. If the patient is on double blood thinners, clopidogrel and aspirin, then rule out bleeding elsewhere also. Casts, very important, but then we all don't pay much attention because it's an indication of tubular damage. Granular cast, sign of underlying kidney disease because glomerulus has come in a cast. They're non-specific and may be found in people with many different kidney disorders. So it's not specific to a particular kidney disease. It just indicates that there is a kidney disease. Fatty cast, people who have lipids in urine. Who will have lipids in urine? Who have very high serum levels of lipid. Or maybe a complication of nephrotic syndrome. Waxy cast suggests very low urine flow associated with severe long-standing kidney disease such as chronic renal failure. Hyaline cast usually caused by dehydration and they disappear once the dehydration is corrected. Excessive exercise or diuretics. RBC cast means there is a microscopic amount of bleeding from the kidney. I just mentioned exercise. I would like to describe a case that baffled me last week. A mother came with her son's report. She said, we went to Goa for 5 days and he was drinking like a fish alcohol. The report showed SGOT double of SGPT. Normally SGOT is less than SGPT. The report showed bilirubin normal. The report showed CPK, creatine phosphokinase, 10,200. GGTP was normal. So I spoke to this person. I said, how much you have been drinking? He says, Goa I drank, but last 5 days, I have exercised like crazy to get rid of that, detoxify my alcohol intake. Imagine extensive weightlifting can give us CPK of 10,000 plus also. And I doubted it could be exercise because normally we do CPK and SGOT when we are thinking of a polymyositis, viral polymyositis. In children, if they have a lot of myalgia, we do that so that we can give them good amount of bed rest. So I knew it can go up, but I didn't know it can go up to 10,000 units also. Urine crystals form when there are too many minerals in the urine. Excessive buildup of one or more minerals, a crystal can convert to a stone. They often occur in kidney and may later travel to ureter or bladder. Stones always form in kidney, but they may travel to ureter or bladder. And based on where they are found, they are labeled as renal calculi or ureteric calculi. Typically, urine crystals will cause no signs and symptoms unless they are large enough that a stone forms. Uric acid crystals, high protein diet, more of non-vegetarian or protein supplements, because uric acid is the end product of the metabolism of first-class proteins. You can see them in uric acid calculi, gout, patient on chemotherapy or tumor lysis syndrome. Patients who is under chemotherapy, when cancer cells are dying, the uric acid levels go up. Calcium oxalate crystals, likelihood of calcium oxalate stones. Triple phosphate crystals, likelihood of triple phosphate stones. Triple phosphate crystals are made up of magnesium ammonium phosphate crystals and are found in alkaline urine, pH above 7 or above 8. The formation of triple phosphate crystals is caused by combination of less urine volume because the patient is consuming less water with bacteria, and which are producing ammonia and increasing the urine pH, making it alkaline. Proteus or Klebsiella type bacteria. So if there is a Proteus or Klebsiella infection, triple phosphate crystals will come up more. Antibiotics for UTI. Frequent infections, both in outpatient and hospital setting, more so in diabetics. I would say that any patient with a fever of more than 24 hours, documented 101, 102, get a CBC and urine done at least. Generally, UTI can be classified into uncomplicated and complicated UTI. With respect to treatment options, how we should treat. Uncomplicated are mainly caused by E. coli, whereas complicated will be caused by Pseudomonas, Proteus, or other bacteria, and may be multi-resistant pathogens. Recurrent UTI are frequently found in young, sexually active women and postmenopausal women, plus those in uncontrolled diabetes mellitus. Nowadays, we are finding culture reports showing a lot of resistant bacteria, resistant antibiotics, and we or our brethren are to blame because we use antibiotics without thinking. So, uncompleted UTI, aminopenicillin, amoxicillin, etc., cotrimoxazole, and even quinolones now are finding resistance. We all must have seen Norflox hardly works. This fact has to be considered in empirical therapy when you are treating without waiting for the urine report. So you have a patient who has fever, who has dysuria, who has chills. You want to start an antibiotic before you wait for the report. Treatment given based on experience without precise knowledge of cause or nature of a disorder is called empirical therapy. Complicated UTI, the complicating factor has to be diagnosed. Is it diabetes? Is it postmenopausal atrophic vaginitis? What is causing it? If complicated UTI not treated in time, severe UTI, and since even E. coli are gram negative, urosepsis is very, very common. Sepsis, septic shock, multi-organ dysfunction syndrome, and death. Avoid empirical symptoms. About empirical treatment, if at all, give only for lower urinary symptoms, too much dysuria, no fever, no flank pain. Minimal test is routine urine analysis, and empirical treatment, the best is, I'll tell you, diagnosis is made with regard to typical complaint and presence of large number of WBCs or pus cells and maybe nitrates in the urine. A culture is unnecessary in most uncomplicated UTI. Should be distinguished from complicated UTI, which has a risk of severe illness. So, a patient who has symptoms, no fever, but is a diabetic, could be complicated UTI. The treatment of choice, short-term therapy with nitrofurantoin, is successful in almost 80% of patients. And this is one antibiotic which in almost 95% plus of culture report is shown as sensitive. Cotrimoxazole, fluoroquinolone, or cephalosporins are not considered first choice drugs. Nitrofurantoin adverse effects are nausea, vomiting, but you can give it after breakfast and dinner, it works well. Diarrhea, loss of appetite, we have not seen much. Interactions, antacid containing magnesium trisilicate reduce its efficacy. So you don't give any digoxin gelusil. Probenecid we don't use nowadays, and sulfenpyrazone also we don't use nowadays. Rapidly excreted in urine, reaches antibacterial levels within 30 minutes of oral. So the effect starts fast and largely eliminated within 6 to 8 hours. Appears to be more effective in acid urine and more soluble in alkaline urine. But for having its efficacy, it needs acidic urine. So vitamin C, 2 tablets. Avoid urine alkalizers when you are giving nitrofurantoin. Complicated UTI, all infections, UTI infections in immunocompromised patient, and commonest immunocompromised patient is an uncontrolled diabetic. Any autoimmune disorder, patient on oral steroids, post-delivery, post-pelvic surgery, post-catheterization. Delivery could be normal or LSCS. Male patient generally should not get UTI. Those associated with fevers, obstructive stones. If you do ultrasound and you find 7 calculi in renal calculi, which are not obstructing, no hydronephrosis, no hydroureter, non-obstructing calculi cannot give complicated UTI. The UTI is not related to the calculi. Patient with sepsis, obstruction due to stones or tumors, patient with catheter inside, or infection involving kidney, pyelonephritis, which is a ultrasound diagnosis, are considered complicated infections. Thank you. Let's look at some questions. After cleaning genitals, ureteral meatus with water, is there any chance of mixing water of drops resulting in dilution? See, A male patient has to just shake the penis once and the droplets fall off. Female patient, you may tell them to use a tissue and wipe, a clean tissue. RBC in urine of dengue patient with 40,000 platelet, does it need to transfuse platelet? No. But then this could be taken as hematuria. Look for other signs of bleeding. But RBCs 8 to 10 is not to be taken as this thing. But if you see 80 to 100, then you may consider transfusion of platelets. Why to give alkalizer in UTI as alkaline urine helps in growth of bacteria? No, that is only for certain antibiotics, not for every urine. When to keep urine acidic and alkaline? Dr. Arthi, I think you must have got the message from the presentation. Can record, make video for matching of colors in 30 seconds. Yes, you can do that if you are doing the strip test in the clinic. Nitrites also are indirect indication of some infection in urine. Best book for standard treatment guidelines and for clinical cases. I will look up, but otherwise standard treatment guidelines are best available on Google, or you wait for our website, which is coming up maybe in a month's time, Indian Doctors Platform, which is going to be a free website. Treatment of uric acid crystal, triple phosphate crystal, just ensure hydration. You don't treat crystals. If the patient is taking too much of red meat, tell them to cut down hydration and check serum uric acid also. Can there be bacteria plus but just 2 to 3 pus cells in this report? Correct? Yes, could be. Contaminated sample. Because certain as up to 5 pus cells are taken as normal, some bacteria will be taken as normal. Nitrofurantoin, you can start 1 BD, 1 TDS depending on symptoms for 5 days initially. If the symptoms are not subsiding, 10 days, but always check a urine report soon after the course is over. Phosphomycin sachet we use generally in very resistant UTI or complicated UTI, or where the antibiotic sensitivity report shows that it is sensitive to phosphomycin only, then we give that. Catheterized patient, how to take samples of urine? You have to use the catheter sample only. How long catheters can be kept? That depends on the patient's condition. If the patient is got chronic obstruction, then you have to keep it for a long time. Thank you very much. Next week, I am getting a PhD doctor nutritionist to talk to you about weight loss and weight gain. And she said, I said, you can cover both. She said, I think weight loss alone may take 1 hour. So a good treat for you next week. Dr. Shweta Rastogi.